lot of effort for successful completion. And organizing a state conference successfully is such a Herculean task that we have seen in the previous years from the previous organizing teams, and we have learned from them, and we have tried to do it here. And now I would like to thank all those who have contributed, small or big, for the success of this conference. At first, I would like to thank President of our State ENT Odisha chapter, Professor Dr. Balabhadra Naik sir. Though he is not present here, but he has continuously supported us through his advice, and it's his advice that has saved this conference. Secretary Ma'am, Professor Dr. Rajalakshmi Panigrahi, has helped us not only by being present here, but her timely advice and her efforts have helped us in many of the difficult situations where we could see no path how to proceed, and it is in those tough times that Madam has helped us a lot. So Madam, I cannot thank you enough for all your help. Treasurer Sir, Dr. Swarupananda Misra, he is like my elder brother, and whenever something happens, the first call goes to him. Bhai, emte hichi kaun karya? So you are a source of brotherly affection for us, and thanks a lot. Our organizing team, which constitutes organizing chairman sir, who is for his health, he could not be present here. So when I was planning how to make the souvenir a good one where people will like, and at that time sir said, okay, you write the messages in first and then the articles, and whatever is your problem, you just tell me, I will correct everything. He is not present here, but still he has helped us a lot. Our organizing secretary, Dr. Anil Das, he is also like elder brother to me, and he has taken immense pressure, because whenever something happens, he is the one whom we all see and ask for. So in that pressure, in that tremendous pressure, he has given this conference shape. So thank you, sir. We have in our team Dr. Sivasis Acharya, Dr. Nilamadhava Prishti, Dr. Girija Mohan. To give a specific credit to someone will not be a good thing. They have worked tirelessly, from wakeful nights to taking all the pain and organizing things. So it was a difficult task, but it could be possible only because of these people. The team has got Asit, Dr. Boydanath Oja, Dr. Rajashree Naik, and they have come late to this department here in FM Medical College, but still they have worked a lot. I would like to thank them all. Our chief guest, sir, Dr. Santosh Kumar Tripathi, has given us time, his valuable time, for the inauguration ceremony. So I am thankful to him. Our Dean sir, our beloved Dean sir, he has helped us through his advice. He has shown us the path how to do things, and he is present here. Thank you, sir. Thanks a lot. Our guest faculties who have agreed to come here, though we contacted them late because of COVID menace. Our previously whom we have contacted, they could not come, and in a short period of time, Dr. Monish Grover, Dr. Gaurav Gupta, and Dr. Nishi Gupta. So they have not only agreed, they have agreed to operate here and to be a part of us in this conference. So no words can thank them, but still I will take this opportunity to give them heartfelt thanks. It is only because of them that we could see such a good live surgery, and we are going to see good live surgeries today also. The audiovisual team, which is mainly by Sachi sir and his friends and his people, they have done a very good audiovisual work, and at night, last night actually, they have worked throughout the night and they have made it possible. It is probably the first time that we have conducted online, and the surgery is being done there about 8 kilometers far away from here, and no wires through internet. So we all had tachycardia, whether this will work or not, or we have to show prasaranare byaghata jogu ame dukhito, but that did not happen. So I am thankful to him and thankful to Almighty for no hindrance to such things. The event manager who has decorated the event, I am thankful to him. We have sponsors who have made this thing possible, made this conference possible. So they may not be here, but my heartfelt thanks to them. All the delegates who are actually making this conference possible, and they are the conference. So every delegate, from our professors, most senior and eminent professors, to the most junior PG students, everybody is here and they are a part of the conference. So I am thankful to all of them. For the souvenir, many of our esteemed otolaryngologists of Odisha have contributed scientific content. So I will convey my thanks, my heartfelt thanks to all those for their scientific contribution to the souvenir. Last but not the least, I may not be able to name some, but they may have contributed to the conference, and I will convey my thanks to all of them. Someone said, it's not important what you have done, but it is important what you could do. When Lord Ram was constructing the bridge to Sri Lanka, the squirrel, which actually took sand particles on his back, was not less than a very big monkey who was carrying a very big stone, because that is what he could do. Many of us, we could do what we could do best. So I would like all of you to enjoy this conference and bless this conference so that we could make it a grand success. Thank you. Thanks a lot.
Thank you, everybody. Now we have come to the end of the inaugural session. Now we'll start the oration. So I would request to clear the podium so that we can start the oration. Thank you, everyone. Please be seated. We are shortly going to start the PT paper session also on the other side in NT1. So postgraduates, be ready, and we'll start the oration very soon, as soon as the podium is clear.
राजेश करा गुड्डे सेटेड ऑपरेशन करतो की देखिए बहुत आगे जाना কিন্তু পানি মাত্র কাটাকুটি কলা কাটাকুটি কিছু কাটাকুটি না ভিতরে আনি সব
पूरा पटरे ना लिखा है
मैम
lessons learned from him, but now we'll learn in short durations and short lessons every year. Now a short introduction for Dr. Gangadhar Bera sir. He was born in 1934 in a village in the district of Balasore. Finished his schooling at his native village and was an alumni of this Fakirman College Balasore again. Completed his UG from SV Medical College Cuttack and post-graduation from Darbhanga Medical College, Bihar. He started his career as ENT surgeon in BSS Medical College, Gurla. Received WHO fellowship from Thailand. Started the postgraduate department of ENT at BSS Medical College, Bulla for the first time in the state. He started the ENT unit at Sistu Bhavan, Cuttack. He worked as superintendent in SV Medical College and director at AHRCC, Cuttack. It is the Regional Cancer Institute, Cuttack. So this was information about Dr. Gangadhar Behera, sir. He is the founder member of Indian Society of Pathology. In 1975, he started the AOI Odisha State Chapter, as sir told, from Paradip Conference. Organized 2 national conferences in 1977 and 1986 as organizing secretary. He was the pillar of success in the 2007 conference which Professor Dr. R.N. Biswal sir conducted. We have some pics of him. This is about the ENT National Conference in 1996. The chairpersons for this oration would be Professor Dr. Pradipta Parida and Professor Dr. Saubhagini Acharya Madam. May I invite them to the stage? Turn for the oration, we have Dr. Mohnish Grover. He has done his MSc from AIIMS, New Delhi. Then he has done his FSCS and he has done senior residency at JIPMER, Chandigarh. He is presently Professor ENT at SMS Medical College, Jaipur. Additional superintendent at the same hospital. He is the nodal officer of cochlear implant program at SMS Medical College. He has a pioneering role in starting cochlear implant program in Rajasthan. He has done more than 600 surgery and has helped 10 centers to start cochlear implant across India and abroad. That's a great thing, sir. Got more than 75 publications to his credit in various national and international journals. His areas of interest are pediatric otolaryngology, especially cochlear implant, endoscopic sinus and scalpel surgeries and parathyroid surgeries. Received numerous awards, including the State Level Merit Award by the Honorable Chief Minister, the then Srimati Vasundhara Raje, on Independence Day for exceptional work in the field of deafness. He has been awarded by the Health Minister, Government of Mongolia, for training their surgeons in cochlear implant and endoscopic sinus surgery. He has headed the expert committee to frame national guidelines for cochlear implant. He has been involved in various philanthropic activities related to deafness and its treatment. Last but not the least, he doesn't only do cochlear implants, he also does photographic, cycling and plays tennis. We welcome you, sir. We are honored to have you here. We welcome Dr. Mohnish Grover. May I have a round of applause for him? Now I would request sir to give his oration.
Thank you, ma'am. Good morning, everyone. Another good afternoon, and thank you, chairpersons. And at the outset, let me thank the organizing committee of 43rd AOICON State Branch, Odisha. And it's a proud privilege and honor to be delivering this oration out here. Special thanks to Anil Dash, Dr. Rajalakshmi and Dr. Preetham for giving me the same opportunity. And also let me apologize for technical glitch that we have right now. Okay, so it's this name, it's like not that I've heard it for the first time, it's all over India. We all know this person, the person probably a major person to start off ENT as a branch in this part of the country. And ever since I'm here and right morning, been hearing the various achievements which he had, and I'm really honored to be delivering the oration which has been started under his name. Okay, so the topic as we discussed is going to be hearing loss, past, present and future. And to start off, the first initial 2/3, let me say, will be on the past and present, and then the next 1/3 will be dealing with the future of hearing loss management. Now at the outset, let me just request all of you to stand up for a minute. If you could just stand up and have a look at what's going on out here. Thank you everyone. And then we all know these things still continue, and it's we should be considering ourselves really privileged that we are not a part of this system which is already in place for many of us. Now this is the place, the major place in my state, that's Rajasthan, and it's really sad to see that such schools still exist. It's kind of a failure of we as otologists, as ENT surgeons, that such places are still existing. Right, and the worst part is probably the word which is hidden right here by a pole. When you see the second word, I'm not sure the pointer is really that bright here, but that second word which has actually been banned completely, that word continues to be still there. And it's not, despite whatever Dr. Rajashri ma'am just mentioned about hearing loss and other things which have happened in the state of Rajasthan, such words and terminology still continue to be used. Now where do we want to reach, right? We just saw one of the things related to our nation. This is another video on that.
आज मैं आपको इंडिपेंडेंस डे का वो अर्थ बताऊंगी जो मैंने अपने इन्हीं कुछ ही दिनों के अनुभवों से सीखा है। बचपन से लेकर आज तक सबने यही सिखाया था। 15 अगस्त 1947 को अनेकों ने अपने देश को अंग्रेजों से आजाद कराया था।
A particular child born like that developing into something like this. This is a patient, a child who underwent cochlear implant at our institute, which was done free of cost, right? And there are many issues when you do something which is absolutely free of cost. But even if you get maybe 10-20% of those kids who develop over 5-6 years like this, you're really happy to see that. And this is one of those examples where we want all those kids to be really present. Right? If you look at the current status of cochlear implants, that's across the world and inside the country, almost internationally about 8 lakh people here with the help of cochlear implants, almost 1,30,000 being bilaterally implanted, 55% being kids. However, we have still 5 times requirement of cochlear implant than what it really exists as of today. If you look at especially India, we don't look at adults as cochlear implantees. We have hardly, even in Rajasthan, it's hardly 10% of total implants who undergo cochlear implantation in adult age group. And globally, 7 cochlear implants per million population per year are being done as of now. So that's kind of an average of million year population if you really look at it. Right? This is the 2008 map of the world. Right? The best countries are around 30 to 60 cochlear implants per million population per year. India was somewhere between 0 to 1 at that time. Right? 2013 we moved up to 1 to 2 cochlear implants, and presently we are around 3 cochlear implants per million population per year. That's still far away from the world average. From the very best countries, it's very, very low. right? So that's where we are really looking at. Now, if you look at the geographic map of India, it's kind of changing. We have multiple new states coming in. We have similarly new cochlear implant centers which have come up, started down south in Chennai, and then it has spread across the country. Now there are multiple centers which are doing cochlear implants. The state of Rajasthan, we started at Jaipur, and now we have many big centers and small centers, others which have started up, but considering it's the biggest state of the country right now, we still have huge, because many districts don't have implant surgical centers. More importantly, we don't have good therapy centers, right? That's rather a bigger issue than just the surgical things. So the reason being, Indian scenario, awareness about deafness is very low, right? The diagnosis will be very late. Even if you have deafness, you would think that there are other mechanisms of which it can be treated. So awareness about cochlear implants is very low, not just among the general public, but even among doctors. What is cochlear implant? Something which we don't probably know as well, right? And then the cost factor comes in, which is a huge issue in our country. And if you look at that policy which are followed world over, the Joint Commission of Infant and Baby had the 136 policy. That was at 1 month you have screening of all the patients, all the people around. 3 months confirm your diagnosis. 6 months you have some or other intervention. India, we actually had a 136-year kind of a policy. We average, intervention about 10 years ago, even at Rajasthan, was like 5 years of age when you did a cochlear implant. So instead of months, it was years. Now the JCI statement has changed to 1, 2, 3 policy. That's for the number of months again. So 1 month screening, 2 months confirm your diagnosis, 3 months do an intervention, hearing aid or cochlear implant or whatever, right? We have, amended our policies a lot to really help out these kids. Now, obviously, important thing is not just a surgery. We have to deal with the rehabilitation issues. So we convinced our government to give free speech therapy to these patients. We had maintenance issues. So over the last 1 year, the accessories and upgrades are being given on a partially funded basis to these patients, and we have to cut the cost. So the patients should also know that we will do this. We have government support, we had philanthropic support, we had government now making policies to give accessories to these patients. This has been there for last 1 year now. And then we have the universal newborn. Can you click on that video? I'm sure everybody, majority at least would have seen this movie of Spider-Man. The quote actually.
Whatever life holds in store for me, I will never forget these words. With great power comes great responsibility. This is my gift, my curse. Who am I? I'm Spider-Man.
When you talk about Spider-Man, right, for us as cochlear implant surgeons, cochlear implant program, we like to believe we are the Spider-Man, right? Because we actually do majority of the work if we consider ourselves. The surgical surgeons' egos are like that. But if you're looking at that power, the responsibility is much more. And we have these gifts, right? And when I meet these kids, it's like a whole family getting together. But when I look at these kind of complications happening, the gift actually soon changes into a curse, right? And we cannot forget one single patient, because that single patient will keep on haunting us for the next 30, 40 years. Because they are not really going to stop coming back to you. You will have to handle them, and that's where it becomes a big issue. Okay, and we need the surgical part of it to be able to manage the intraoperative issues. Right? We will have, when you open up the cochlea, I'm sure the people who are doing cochlear implants, they must have seen CSF gushers happening out. Then we need to know how to handle those issues, and being able to put in those electrodes at the right place despite having intraoperative problems is something which comes with experience. But it is important that we really know all these steps, and we know when to involve somebody else if we think that will be the best thing for our patients. So importantly, the egos of surgeons that I'll be able to do it is not something which we can really do, especially in cochlear implants, because it's going to be a one-time thing in majority of these patients. And that's what we need to be careful about. Right now, can you play that video again, please? Okay. Can you, excuse me, audiovisual, video play kar denge. Now there are various ways to handle a CSF gusher, right? One of the ways would be to really just put your suction near the opening in the cochlea, keep on sucking out the excessive egress of the fluid and then insert your electrode array, you can actually thread your electrode through a soft tissue, and that actually seals the CSF gusher when you have inserted the electrode. So that's one of the things which we are doing out here. It's always better to do a bigger cochleostomy. That seems contradictory to what we are planning to do, but that actually is better to seal the tissues, seal the opening with the help of tissues around the electrode space. So bigger cochleostomy is always better off if you are looking at CSF gushers, and the worst scenarios, if your tissue glues or subtle petrosectomy, which are very rarely required, is usually this thing which helps us out. And that's why we have various classifications for inner ear malformations. We have had our own classification which we now really like to follow, and that's based on much more simpler things. When we as surgeons look at it, much more practical, which we find, and that's something which we really believe in now. But we also need to realize that even after your first surgery, which goes on very well, you may actually need to require a revision surgery, which could be because of millions of reasons actually. The commonest being the device failures, infections, rejection of the electrode or the implant, migration of the electrode outside the cochlea, damage to the electrode during insertion, and displaced magnets. Right now, implant failures is something we are looking at. Right, I had had a few meetings with Dr. Mohan Kameswaran sir. I'm sure everybody knows him, and he once told me that if you have done 500 implants, these are the patients who will keep coming back to you and keep you busy with their revision surgeries. Right, and that's a very true thing, because the internal implant is going to fail. It's kind of any electrical or electronic machine like your wristwatch or mobile or your washing machine, which is going to stop working after a few years. Luckily, the average time world over is around 20 years. So if I'm doing an implant on a 3-year-old kid, that child probably needs 2 revision surgeries again in his whole lifetime if the present technology continues, and that's continued over the years as present technology. So 3 years and maybe around 25 years, and then maybe around 45 years. And if he lives longer, 65 or 80 years. So that's what we are looking at when these patients are being operated by our own hands. And if a second surgeon comes into step, when we are not there anymore to help these kids, he may not like the way we have done that particular surgery. So we need to realize that's going to happen. If however you are going to do a revision surgery, always remember that your newer electrode should be either of the same model or shorter and slimmer than the previous one, because the cochlea is now not as big as what it was when we did the first surgery. So you have to make your life more tricky. Now, interestingly, this particular surgery which I'm showing, this is a patient who underwent cochlear implant at some other center, paid from his own pocket. Then he had a trauma and the implant stopped functioning. Now, the first implant was a metal implant, right? And at our place, the tender is of Advanced Bionics, and he wanted a revision surgery at our place. Now, luckily for us, Advanced Bionics electrodes are smaller than the metal company electrodes, so we were okay enough to operate. I have never done kind of a revision surgery with a different company, right? But this was particular where we had no other options. Now, importantly, when you are dealing with this kind of thing, there's a lot of fibrosis and neo-osteogenesis which has taken place. So you have to deal with it, taking care that you don't damage the cochlear implant which is already existing. You need to save it as much as possible. As soon as you remove this electrode array from this, these are 2 implants in place, right? The first one and the second one, because of different companies which are there. Right? When you remove the first electrode array, immediately insert the second electrode array. That's very important, because the capsule around the electrode array in the first surgery is going to collapse as soon as you remove the electrode array. If the capsule collapses, you lose the cochlear lumen. Right? So you remove the cochlear electrode, the first electrode, and you insert the second electrode within a few seconds. Right? You don't want to lose out on that lumen. Once you lose out on that lumen, the surgery is going to take a hell lot of more time. The second issue, which is much more common as we are increasing in number of centers, is infection. Now, and it's, believe me, I have looked at all of these kind of issues with the skin and soft tissue and subcutaneous tissue when you look at it, and it's much more than what is probably reported across the country and the world. And it's really sad to see these patients, because majority of them ultimately land up with an explantation. And once you give an hearing to a person who's not able to hear, you take it back, it's probably worse than the first scenario. Right? You were not able to hear, you adapted to it, you did an intervention, made the child hear, and then you tell him you can't hear again. Right? That's probably the most sad thing which is possible when you're dealing with a cochlear implant program. We had our own grading system for it, and we graded them as per our this thing. Sadly, And look at the grade 4, that's the last grade which we actually see out here. That's the worst part of it, and majority times, as I mentioned, the best thing would be to explant and do a cochlear implant in the opposite ear. Right? This first ear is gone now. Issue, however, is, especially if you have a government-funded implant or some philanthropic society, they won't really give you a second implant in majority of the cases. Right? That becomes a big issue. So what the issue which we had now is, can we save this implant, because that's already an infected implant. We know infected implants traditionally have to be removed, and we really believed in this gentleman when he said yes we can, and we tried to follow his words on that, and we tried doing things differently, and making our own incisions, a huge flap being required on the inferiorly based on the occipital artery, imagining a new site for this kind of an implant, and making this incision, elevating a flap, then elevating a separate musculoperiosteal flap which is superiorly based, removing all the granulations, the biofilms which you can see near the first implant site, taking care of that in the biggest way possible, being very thorough with it, dealing with the tie down holes, making a new well much more inferiorly away from the first site, and then trying to suture it back into place, covering it with as much as possible, and then you get this kind of an incision coming in. First of all, forget that a very small incision would work out. I have tried my hands on just removing the infected part of the skin and doing the primary suturing. It has always failed. And look at this. This is what the post-operative looks like. This is around 1 month post-op. Still, you need to remember that even after this, almost 50% of patients undergo explantation. It's not that this is a good surgery to do. I hate doing this surgery. Just that we give it a try once, and this is a try. In fact, I did one about 1 week ago before coming to this place. A patient who just had an issue because in the first surgery which was done, the surgeon had placed the receiver sphincter package much more anterior. Now, considering that happened, the external part was hitting on the internal part, and the in between skin got necrosed. So the first surgery is not something which we take lightly. Any step of it is actually going to be very important. Now, issue with again is when we start off, the electrodes going into wrong places, and there are instances. If you look at the world literature, they have reported everything you can imagine. These they are going into the eustachian tube out here, going into the near the facial canal, into the vestibule, and multiple other places, right? So wherever near the temporal bone you imagine the place, people have put in, the most experienced surgeons have put in into various other places. And just a case, which we had, this is a 60-year-old female, progressive hearing loss and diabetes, hypertension, poorly controlled, underwent the cochlear implant surgery in 2015 at a center, and the operative notes actually mentioned that there was cochlear ossification present. There was incomplete electrode insertion, and when they did an intra-op checking of the electrode array, they were short-circuited 2 electrodes, and the intra-op E-cap thresholds were only between 6 to 11, right? And so it means the cochlea was inside the electrode somewhere because it was stimulating the cochlear nerve, but obviously this is not something which looks good, right? These are the photographs of the intra-op E-cap threshold which the audiologist had. When the patient came to me, we really got this X-ray done. Now this is the X-ray. Obviously it's not showing the curve of the cochlea which you want to see. It's showing a lot of kinking around there. The patient did not show any improvement, and otoscopy actually showed a marginal perforation in the posterior part, right? When the surgeon, when you do posterior tympanotomies and you're trying to make it very wide because you're not happy with what you're getting, you actually damage a lot of things. So you don't want to. Got a CT scan done, right? That's the importance of a CT scan. If you look at it, it's actually going on from, if you look at the green pointer out here, the electrode is going here, that's your cochlear turn, right? And it's going much more deeper inside, right here, right? And that's in fact inferior to the cochlea. If you look at the axial sections, look at these sections one by one, it's right now going inside the cochlea. If you see this electrode array, this is the electrode array, that's your basal turn of cochlea, and it's entering the basal turn of cochlea right here, and then it exits the basal turn of cochlea, keeps going. That structure which you see is actually the carotid canal. So going towards the carotid canal, and it's present inside the carotid canal, in between the carotid artery and the bony carotid canal, right? So that's where the electrode has actually gone in. Now, what probably happened is the surgeon when operating was drilling a bit too much. That's where your overconfidence or ego actually makes us do. without seeing a lot of things, drilled too much, and he crossed the basal turn of cochlea and went inside the carotid canal. Seeing the pulsations which were given from the carotid canal, we thought that probably it is the lumen of the cochlea, and inserted the electrodes there. Right, and this is the revision which we did. Now, patient didn't have a lot of money. We didn't have. Can you play that video again? Sorry. Now, we actually had to take a consent that this may not work out, because if it is really, as you can see here, it is really stuck, and we can't really be rough when you're dealing with a carotid artery at a 60-year-old woman, right? And we dissected it off along the posterior tympanotomy at the site of opening in the cochlea, which was done, and finally we could just, kind of remove it there, and we look at the, the shape of the electrode, which is all, the worst thing possible is when you have a kinged electrode area, because that would not really make any space for you to put it in. We drilled again, that was a neo-osteogenesis which probably had happened, or a small enterostomy which was done initially. Tried to look for a space inside the scala tympani or the scala vestibule of the basal turn. Didn't really work out, and we realized that we are not getting any lumen inside the cochlea in the usual place. We knew there was a posterior marginal perforation which we had to repair anyhow, so we elevated a tympanomeatal flap. Then we went through the middle ear now and decided to do a middle turn cochleostomy. Right? And this was the first time I was doing a middle turn cochleostomy. That's in 2015 or 16. Right? And the landmark for that would be, you just go 2 millimeters interior to the oval window, just inferior to the processus cochlearis formis. Now that's where you need your friends and seniors for. I had discussed this with Dr. Keertan. I had an intraoperative with Dr. Mohan Kameshwaran, and they told me what's the best way to do a middle turn cochleostomy. We threaded the electrode area through the posterior tympanotomy, and then inserted electrode by electrode inside the middle turn cochleostomy, which we did. Now we got this kind of an NRD, right? And we saw around 16 electrodes working. We did not have the basal turn to place. So pretty okay. Post-op scan, look at it, the basal turn is not really having any electrodes, right? It's just the middle turn and the part of apical turn which we now have electrodes in. So obviously not the best thing for the patient, but this is the best you could do for this patient, right? The other revision surgeries which are simpler to deal with would be a magnet. We normally see a magnet in the center, but if it gets displaced inferiorly or somewhere else, that's a displaced magnet inside of the inside package, right? And then you need to replace it back. It's comparatively a revision surgery, but a much simpler one. Give a small incision right above the RS package, elevate it off, and you see the magnet which is not in its place. You just put it right back into the pocket, right? That's where it goes inside the pocket. The only thing you need to be careful is use non-magnetic instruments to hold on to the magnet, right? Because the magnet otherwise not really allow you to put it inside. But it's comparatively much simpler surgery. Now, interesting surgery, right? This is one of those patients, underwent implantation about 2 years ago, was doing well. He just came to our audiologist from, I think very far off, not from the same state, with just a complaint of minimal swelling and not really doing as well as we would be happy with. This is the X-ray which we got. Now, if you look at this X-ray, on the first look it went pretty okay for me, but now you look at it, if you see this package inside, that's a dummy implant, right, which we use during surgeries, and the first surgeon by mistake has left it inside the body, right? And these are the small mistakes which as surgeons, everybody of us can commit, right? And obviously we didn't hold any records for this, and very small surgery required, but for the patient it becomes a big issue, right? And that's where it's an issue problem for us. Okay, can you play that video for me, please? Now, importantly for cochlear implants, and never leave the patients till the end, right? You will have to be there for them. They will come to you for their family problems, for everything actually. They have issues with getting school admissions, need to talk to the school authorities many a times, but that's how it works. So that's what past and present was about. Now just a few slides on the future, what we are looking at. For me, if you ask me, has everything really changed in the last 20 years when you deal about cochlear implant technology? Almost nothing has changed. Right? The basics of cochlear implants still remain the same. And that's really sad to see, because with physics, the things change very soon, and we really expect that a lot of things would come in. And the present which we now look at is very different, right? That was kind of an unimaginable future maybe 30, 40 years ago. And we have to look at various things which have changed over the last 20 years or so, right? From a huge setup of a big PC and everything, now we have a small mobile in our hands. So everything has changed. Sadly, the cochlear implants have not changed as much as they should have. And we really look at the various studies which are going on, which hopefully we'll see in the management of hearing loss, which are existing, right? And the options which we have, especially about cochlear implants, are optical stimulation based cochlear implants, biohybrid cochlear implants, and nano series. Now, we all have been to discs, maybe a banquet which follows today will have these kind of lights. And the interesting question is, can we hear those lights, right? That's something which we need to look at. And that's what an optical cochlear implant is actually based on. Now, what it really, somebody can play that video again, sorry. Technology is not easy, right? Cochlear implant is not going to make it easy either. So these are the present electrodes, right? You stimulate a lot many spiral ganglion cells. You are stimulating, you have 20,000, if you have 20,000 ganglion cells, it's actually much more. You're using only 20 electrodes to stimulate that, right? Now optical base would be stimulating very specific electrodes. Very specific spiral ganglion cells. So it's going to be more precise. So as compared to when we have only 12 or 16 or 22 electrodes which are present in the electrode arrays, if you have an optical cochlear implant, you would have a huge number of electrodes coming into place, right? And these are based on two mechanisms: photoacoustic effects and optogenetic effects, right? Okay, can we play this video again? Now, the photoacoustic effect is, when you give an infrared light, it gets absorbed and then it expands, right? Then when it expands, it stimulates. So that's what a photoacoustic effect is based on. And that's why people are doing is giving light stimulation in the near infrared spectrum, which gets absorbed by the perilymph, and when it expands, it stimulates the nerve ganglion cells. That's one of the mechanisms which the world is looking at. The other mechanism is optogenetics. Now, we have various algae in the world which actually have photosensitive molecules. They are able to respond to light. Now, what the people are working on across the world are getting their DNA, putting it inside through the round window, and then changing these cells to really respond to light. That's what the world of optogenetics is looking at. And so when you give light with the help of your electrode array, which actually carries light, you would be, those neurons which have become photosensitive now would generate electric current, and you would be able to hear. And that's obviously going to make a huge difference for the patient who is able to hear. So as I mentioned, you would have like 144, that's one of the prototypes which is being developed, 144 LEDs instead of 12 or 16, 22 electrodes which we presently have. Right? And NOCI is like based on neurotrophic factors. So it's a biotin derived neurotrophic factor which is being used presently, which the electrode arrays would have.